So today we will start our family medicine review. So in family medicine, the screening and all those are like highly important and like lots of questions from the screening part. And there are like different websites. Like there is Canadian Task Force, and then that is like the main one. But there are some other recommendations from Choosing Wisely. They have mentioned it here. So we will try to cover some high yield stuff from all these websites, so then at least we have like this one like recording so we can review it later also. So in the let's start with the periodic health examination. So the first thing they are saying, Canadian Task Force on Preventive Health was established in this and all this. So basically the Canadian Task Force is the main organization that is giving all the recommendations for the screening and everything. So then everyone is following that like screening for the preventive healthcare. So that is the main website. We will go over that like for the few important screenings. And then adult periodic health, male and female evidence based preventive health checklist. So this is just for the physicians, the checklist, like in which age group they have to monitor, like to do which screening kind of. So what is the basic purpose of the periodic health examination? That is primary prevention and secondary prevention. So these both preventions, and the other one we have read in detail in the public health. So basically, what was the primary prevention? Identify the risk factors, so that like the disease is not actually there, but we are trying to identify the risk factors and then promote, like do the health promotion and all that. So that that is basically the primary. And what is secondary? Like secondary is to prevent disease progression, so like screening programs and I think vaccinations, so all those are included in the secondary. So this is just the great classification, like how the Canadian Task Force is giving recommendations like weak and strong and all those. So this step, like this thing is very important. Folic acid supplementation, and like the dosage of the folic acid is also very important, like in the preconception area, like timings, and then in the high risk women. So in the, because it prevent the neural tube defects. And so in the low risk woman, like if she has no personal health risk or anything like that, so then diet rich of folate and a daily oral multivitamin, and the dose is zero point 0.4 to 1. So this is for the regular population, at least 2 to 3 months before. So if a woman is coming, they are like she is planning to have pregnancy, so then this is the dosage for if no risk factors. And then it's continue 4 to 6 weeks after. So it is start 2 to 3 months before conception and then 4 to 6 weeks postpartum. And then in the high risk women, health risks include epilepsy and BMI more than 35, insulin dependent, and special ethnic groups. So in these with the high risk, 5 ml folic acid for at least 3 months. So this is important to remember the dosage. So they will give some risk factors and all this to identify, and then they can ask like what dosage you are giving of the folic acid. So from 12 weeks post conception until postpartum period, 4 to 6 weeks, or as long as breastfeeding. So zero point 0.4 to 1 is sufficient. And women with additional lifestyle issues, so this is, but like the main thing is to remember the dosage. And now the periodic health exam. So this is just like the, in the periodic health examination, what discussion should be there, like for the dental hygiene, screen for poverty, counsel on smoking cessation, and then dietary advice, moderate physical activity. So this all the counseling should be done in the periodic health examination for the general population. But for the special population, like in the pediatrics age group, adolescents and perimenopausal, so then there are like certain important other stuff that needs to be counseled. So for the children, home visits for high risk families, injury prevention, poison control. So this A is high quality evidence and B is moderate. So basically A is the main one, like the main recommendation. So this is A, injury prevention and all those things in the pediatric because of child abuse and all those conditions. And in the young population, sexual activity, contraceptive method. So in addition to the main counseling, these are the important ones that cannot be missed, like adolescents and pediatric and then perimenopausal. So the substance abuse, smoking, sexual activity, all these are important to be discussed with if for the adolescents population. And then the perimenopausal, more than 50, assess for osteoporosis and fracture. So osteoporosis and fracture counseling is very important for um, like the perimenopausal. And what are the physical things that they are doing? Blood pressure, height, weight, and this is all done in periodic health examination. And for the adults, follow up on caregiver concern of cognitive impairment, multidisciplinary post fall assessment. So this fall assessment for fracture assessment and all these are very important for the adults in the seniors, right? And then repeated exam of hips, eyes, and hearing, especially in first year of life. So these are done in the first year of life. And then hearing impairment, voice test, audioscopy, this is all for the seniors. And first degree relative with melanoma, full body skin examination. So this is important because they have written is like a in a different line. So if there is a family history of melanoma, then full body skin examination is very important. And then and what tests are to be done. So this one is the age and gender specific screening for diabetes, dyslipidemia, hypertension, cancer screening. So these all are done according to age. So we will see like which age group we have to see do which is screening. And this is one time screening for triple A in men age 65 to 80 years. So this is also one of the very important screening. So we will see in the Canadian task force, but this is for basically for men 65 to 80 years. And then for special pediatric population, routine hemoglobin for high risk infants and blood lead screening for high risk infants. So this is for high risk, not for the general. Then TB and STI and syphilis. And then accordingly, the therapy is given for the folic acid and rubella vaccine for all non-pregnant women of childbearing age, and then varicella 1 to 12 years, all this vaccination schedule. And this is for the special population like influenza in the high risk group, and then HPV high risk group, female, age 9, and then TB. And then in the immunocompromised and age more than 65, COPD, asthma, CHF, asplenia, so diabetes, so this all immunocompromised. Pneumococcal vaccine is also given. So Pneumovax 23 is given for all more than 65 and all the high risk population. And then Prevnar 13 is more than 65 and high risk. So this pneumococcal vaccine is very important for the immunocompromised and more than 65 years population. So this is like the basic recommendation for the periodic health examination, like what to be screened and which tests are done in which specific population. Now we'll see the specific guidelines for the
Pneumovax, Pneumovax and Prevnar, they are the same one? Pneumovax 23 and Prevnar 13.
No, I think they one is 23. It has the PP pneumococcal vaccine like 23. I don't remember the name, and then there is a 13 also.
Okay. Pneumovax and Prevnar. Okay, thank you.
No, the Prevnar is given during childhood, but this the meningococcal this is for the adult.
Mhm.
Okay.
So all these recommendations are just for the from the Canadian task force and all those and up to date. This is the references. So now we will see what is breast cancer screening guidelines from the Canadian task force. So for the breast cancer, all the women should be screened for 50 to 74 years. Recommend screening with mammography every 2 to 3 years. And the decision to undergo screening is conditional on the relative value that a woman places on possible benefit and harm and all those. And a woman 40 to 49 years recommended not screening with mammography. The decision to undergo screening is conditional, so depending on the risk factors and all those, but the main recommendation is 50 to 74 years every 2 to 3 years. And then for this age group is like the risk and benefit and all those things. And then recommend not to perform clinical breast examination to screen for breast cancer. So self-examination is not recommended. And recommend not advising women to practice breast self-examination to screen for breast cancer. And recommend not using MRI. So basically the mammography is done.
This
And
means that we will not clinically examine the breast examination for the screening, yeah, for the breast
yeah,
cancer. The
yeah,
physicians perform for
yeah.
screening. Okay.
Clinical breast examination is not recommended routinely. And then MRI is not done. And for more information on breast lesions and cancer, so this is in the next chapter. So we will see the screening here, and then we will see it from the Canadian Task Force just to make sure. And then for the lung screening, it is all 55 to 74 years. So here it is 50 to 74 females, and then here 55 to 74, all adults. And with more than 30 or 30 pack years smoking history, who currently smoke or quit less than 15 years. So in the question stem, if they are giving any person who has quit smoking more than 15 years ago, so then he is not eligible for the in the screening guidelines. But if he has quit smoking within 15 years or he's currently smoking, then he is eligible for the screening. And then recommend annual screening with low dose CT up to 3 consecutive times. And screening should only be carried out in healthcare setting. So every it's like annual screening and then up to 3 consecutive times. So this
It
is
means
with
that if the person has stopped smoking for about 20 years, then he will not fall for the screening of the lung cancer. Yeah.
no, no.
Okay.
And then all the adults, regardless of the age, smoking history, or other risk factors, recommend not screening for lung cancer with low dose CT. So these specific criteria should be met for the screening for low dose CT scan. Like all the other, even if person is just smoking, like but he didn't met this 30 pack year smoking or this, so then he's not eligible for the in the like he's not in the recommended for the screening. And then recommend that chest x-ray not be used for screening of the lung cancer. So basically it is low dose CT. Chest x-ray is not recommended. So these 2 and 3 points are important here. So now this colorectal cancer screening
But,
is a
doctor, can you tell about low dose CT again? What was said about low dose CT?
so only the low dose, they recommend only the low dose CT should be
Yeah.
used for the screening purpose. Like the chest x-ray and all the other, like with or without sputum or whatever, those tests are not used for the screen for lung cancer. Basically, they are doing the
Who are not screened for lung cancer with low dose CT? Recommended. It's written recommend not screening for lung cancer with low dose CT. For all other adults means who?
Other than this, like who are not smoking.
Okay. Okay.
suppose a person is coming 25-year-old and
Yeah.
he is like he's a regular smoker. He is
Yeah.
smoking, suppose he's smoking like 1 pack a day,
Yeah.
and he's smoking for 10 years and he's 25 years.
Yeah.
So will he be eligible for smoking or not?
Eligible for
No,
screening.
no, 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 you won't.
No. No.
No, right? Because he is not in the 30 pack year smoking,
And not
because
in
Yeah.
years. Yeah.
he is not in the like in this age group.
Yeah.
So that is this thing, like all other adults, whether they are smoking or whatever they are doing. But
Okay.
if this is not met, then
No
I think
screening.
there are some MCQs like that, like a person is coming and like his friend has lung cancer, whatever, and he is scared of the lung cancer, but they gave all the criteria, but if it doesn't fit this thing, then we will tell them, oh, like you are not like it is not recommended, that screening is not recommended for you. So that is why it is important to remember this criteria. So whatever they are giving in addition to this, then we can adjust, right? So that is the thing.
Thank you. Thank you.
Yeah, so this colorectal cancer is kind of little bit complicated, so we will see how it goes. So first thing is the age groups, 60 to 74 years. And but we are not doing the regular screening with colonoscopy. The regular screening test is FOBT or FIT. So this is important because sometimes we think, oh, the colon screening, colorectal screening is the colonoscopy, but the basic recommendation is FOBT or FIT for the people who are 60 to 74 years. And how often we have to do it? Every 2 years. Or flexible sigmoidoscopy 10 years. So if we are doing FIT, FOBT every 2 years, and if we are doing flexible sigmoidoscopy, then it is every 10 years. So these are the basic tests that are done. Now the second thing is screening adults 50 to 70, 50 to 59 with FOBT, FIT or same. So basically our age group is from 50 to 74, right? So the colon cancer is 50 to 74. Now lung cancer
Same
is
like breast cancer, like 50 to
55.
74.
Yeah, so breast cancer and colon cancer are 50 to 74, and then lung cancer is
55 to 74.
55. Yeah. So now the first thing we see, this is for the regular population, right? And now the recommended not screening adults more than 75 years. So it is still 74 years. So after 75 for the regular population, we are not doing it. Recommend not using colonoscopy as a screening test for colorectal cancer. So colonoscopy is not used. Now we will see this chart, like what's going on here. So first thing is like this screening is for the asymptomatic patient, like say asymptomatic person who has like no other symptoms, who has like no family history. So this is our regular. But if the patient has any symptom, man or woman, then we have to do diagnostic workup. Then obviously with the symptom he is not fit in all this criteria, like he doesn't met the screening criteria if he's symptomatic. Now, if he's asymptomatic, regardless of the age, but positive family history. So the first thing is the symptom. Now the second thing is the family history. So if it is a positive family history, so then different things can happen. So if the first degree relative uh, has cancer or adenomatous polyp at age less than 60, or two or more first degree relative with polyp or cancer at any age. So basically, if any first degree relative had any cancer, then we have to do colonoscopy every 5 years, or at 40 age 40 or 10-year younger. And here, if the first degree is like more than 60 or two or more degree, more second degree, then the patient is at average risk screening. And this is also began at age 40. So even if the first degree relative is above 60 or below 60. So we can just remember, if it is a first degree relative, then what we have to do, we have to start screening at age 40, because these all make it more complicated. So easier way to remember is like first degree relative at any age less than 60 or more than 60, we have to start screening at 48. So if a person is coming and his father has like colon died of colon cancer at age 63 or whatever, and suppose he is 50 years, so what should we do?
We should go for the colonoscopy because 10-year younger also.
Yeah, so we had to start at 40, but he's already late, so we will start it right away. And then colonoscopy every 5 years, and this person is also average risk, so we'll start at 40 years. So this is about the first degree and second degree. And now if the one second degree relative or third degree, average risk bigger than 50. So this doesn't make that much sense because this is the regular screening population, because our regular screening start at age 50. So if they say a person comes like whatever, like age group or whatever, but his uncle had a cancer or his cousin has a cancer, so at what age the screening should be started. So that is just to make us confused, because the in that case, in second degree, whether uncle or cousin or anyone, the he's average risk, and the like the screening starts at age 50. Only if he's like first degree, like the mother, father, or like siblings. So those are first degree, but the uncle, cousin, and all those are second degree. So those ones we start at regular 50. So this is this, and then this one is high risk, and the first one is high risk, because polyps found at colonoscopy is very important. So if it is 1 to 2 adenomatous, then colonoscopy in 5 years. So any polyp found 1 to 2, colonoscopy 5 years, and more than 2, colonoscopy 3 years. So this polyp is like high risk. An incomplete examination, numerous polyps, and malignant colonoscopy after a shorter interval. So depending on the patient condition, but these are the more than 2 is 3 years and less 1 to 2 is 5 years. Now the first one, this is also very high risk, HNPCC or FAP. So then we have to do genetic counseling and special screening. And in HNPCC, colonoscopy every 1 to 2 years, because this is very high risk group, and begin at age 20 or 10 years younger than the earliest case in the family, whichever comes first. And same FAP, it is like much younger, 10 to 12 years. So these are very high risk groups. And then AAPC colonoscopy annually begins at age 16 to 18. So this first column is the highest risk, then the polyps, and then these are all the relatives one. So this is all the colon screening. So anyone want to just quickly review the colon screening, because I think it is too much to memorize.
Actually, in the colorectal cancer, the screening begins at age 50 years, normal screening, and it is done with the help of FIT, FOBT or FIT.
Or fit, yeah.
Yeah, every 2 years, 50 to 59 years, every 2 years for the colorectal cancer or flexible sigmoidoscopy every 10 years. Then for the adults which are fall in 6 to 74, we also do the
So
same.
basically, sorry, so basically we can just memorize 50 to 74 years
54,
because it is
50
same.
to 74, it's the same like fit and fob.
Yeah, yeah.
FOBT,
But we will not
two out of,
recommend colonoscopy. Yeah, for as a screening
yeah,
test for pregnancy.
colonoscopy, they have mentioned that it is not used
Not
for a
recommended.
screening now. Yeah, we don't
Yeah.
use it for screening
And we
purposes.
will not
It's
screen
just like
adults more
diagnostic
than
purposes.
75 years.
Yeah.
Yeah. Yeah. Not screening adults more than 55, 75, sorry, 75. Yeah. More than 75, we will not screen the adults. Yeah, then we came to the table. In the table, there was three things main. One was the FFP. In this, we do HNPCC, colonoscopy every 1 to 2 years. This was high risk, and it begins at the age of 20. And FFP, and it was done at the age of 12, and AAPC at the age of 16 to 18. Then we polyps. Polyps were high risk. If the one polyp or two polyps, then every 5 years colonoscopy. If more than two adenomas, then we will do colonoscopy in 3 years. And then the relatives, first degree relatives, these are high risk, means that we will do colonoscopy every 5 years, begin at the age of 40. If they have a two or more second degree relatives, then we will this is average screening, and we will begin at age 40. And if one second degree or third degree affected, then it will be less risk, and we will begin screening at age 50. Yeah.
Yeah. So now the next one, this one is also very important, cervical cancer screening. So this one is we are doing the pap smear every 3 years. And what is the age group? Basically, it is 25 to 69. So this is 25 to 29 they recommend pap smear, and then 30 to 69 they recommend. And in the Ontario guidelines, basically it is 21, but we will follow like the Canadian Task Force. So that is 25 to 69. So we are doing
Isn't it 11 to 25
11 to 25 for cervical cancer,
for pap smear?
No, 11 is
11 to
not
25.
recommended.
No.
It's too young.
Oh, okay, okay. I think I misunderstood, but I think
I
I read
think
it
you are
somewhere.
talking about the
Human
vaccination, Dr.
papilloma.
Cell.
Oh, yeah, maybe
Yeah,
HPV
that is the
vaccine. Yeah,
vaccination.
yeah, yeah.
Usually, the grade 7 students receive here.
Yeah, okay, okay. I got it. Yes. Then thanks.
HPV
No
vaccine.
worries.
Yeah,
Yes,
HPV
it's
vaccine they get
HPV
right.
vaccine we give like from 11 to 25 years.
11. Okay.
Mm-hmm. So, what Canadian Task Force recommends for cervical cancer screening, the age group is 25 to 69. So, that we have to remember. So, we do the pap smear, and how often we do it? Every 3 years, right? So, that is the first thing. And then, women more than 70 who have not been adequately screened recommend continue screening until three negative test results have been
Okay.
obtained. So this is important because sometimes they ask us, like the woman is 74 years or whatever, so whether we should do the pap smear or not. So if she have the last three pap smears negative, then she is good, she doesn't need it. But if any of last three, if any of the other like abnormal findings are found, then we continue the screening. So for women age 70 who have been adequately screened, three successive negative pap tests in the last 10 years, recommends routine screening may cease. So this is also important. Adequately screened means she has to be regularly screened for the pap smear. If she misses her screening, then she is not adequately screened. So then she doesn't fit in this criteria.
Consecutive negative test pap smear na, in the last 10
Yeah,
years. Yeah.
yeah.
Yes.
Yeah. Okay.
So now provincial and territorial guidelines may be different. For example, Ontario, women more than 21 years and then updated to 25 who are or have been sexually active recommend screening every 3 years. So basically in Ontario, the age group is 21. And then women may discontinue screening at age 70 if adequate and negative cytology. So two things are important, adequate and negative. Oh, this is not only like, oh, she has the three negative, but like, was she adequately screened or not?
And
In the,
successive also. Consecutive successive also. Yeah.
yeah, in
Mhm.
the previous 10 years.
Mhm.
So three or more negative cytology test. So now we will see this chart. So the first thing is like if the woman is coming, she did the pap test, if everything is normal, okay, she's fine, come back in 3 years. If inadequate sample, like the screening cannot be done, okay, repeat cytology in 3 months. If adequate sample and no, like nothing is found, I think, no TZ,
Transitional zone.
transition.
TZ is transitional
Yeah.
zone, that is
Transition.
squamous columnar.
Okay, so if no transitional zone is found and then she is good every 3 years. Now here the thing begin, like if there is ascus present or if there is this asc H or this one agus, LSIL, HSIL or squamous. So if these are present, so it is easy to remember, I think, if all of these, like the ASC H, like their abbreviation is written, abnormal squamous cell, cannot rule out HSIL, and this AGUS, LSIL, HSIL. So all this are like kind of high grade. So then we have to do colposcopy, colposcopy, colposcopy. This one is colposcopy, this one is colposcopy. So all the high grade are colposcopy. So in the ASCUS, what we do, in the ASCUS, we first see if the woman is more than 30 or less than 30. So if she is less than 30 or HPV testing not available, then we have to do repeat cytology in 6 months, then negative, repeat cytology in 6 months, negative, then routine screening. So if the ASCUS is present, then we need two negative screening done in 6 months and 6 months before the woman can go to routine screening. So this is this thing. And if after 6 months we repeat it and again ASCUS is positive, here it is negative, right? Then we directly do colposcopy. So after ASCUS, if there is one ASCUS again, then directly go to colposcopy. Now, in the woman more than 30 years, this HPV DNA testing is offered. I mean, it is not mandatory because, but if it is present, then and a woman is more than 30 years, then we offer this testing, but it is not publicly funded and then they have to pay with their insurance or whatever. So that's why it is like not kind of mandatory, but we have to offer if it is there. So, and the woman is more than 30. So if it is positive, directly colposcopy. If negative, repeat in 12 months. So basically that is the, and also here, like all these are colposcopy, but in the low grade LSIL, what they are saying, it the colposcopy can be done or the repeat cytology in 6 months can be done. So what is the criteria in which we do colposcopy directly or we do repeat cytology in 6 months? Anyone have any idea? Hello?
And no idea. I don't know.
Because see, in all the other, they directly tell you atypical and endocervical cell, go to colposcopy. This one, go to colposcopy. High grade, go to colposcopy. Squamous, go to colposcopy. But here, they have written either do colposcopy or do cytology in 6 months. So basically, how to differentiate is that like according to risk factors. So suppose if like 29 years age woman is coming, she has multiple sexual partners and like all the her like sexual history and all those, like kind of she is high risk, then we have to do it like colposcopy right away. But if the woman is like not high risk and monogamous relationship or something like that, then we can just like take time and just repeat it, and in 6 months it can be negative, and then again 6 months can be negative, and then do the routine screening. So in the question stem they can throw some of those like risk factors, and if they mention it is like LSIL, then what you are going to do. So then according to the like the history and the the high risk factors, we can choose any of these. But if it is like ASCUS is positive, then again we do the colposcopy right away. So basically that is the whole story. So anyone want to repeat this, because this is like a kind of huge one.
In this one, in the normal, we will repeat the repeat routine screening is done in 25, 25 to 69 years. The routine screening is done, and for the women of age more than 70, if they are three, we will say to have three successive tests, and if there will be three successive screen tests negative, then we will stop screening in the last 10 years if they are negative, and its age is more than 70 years, then we will stop screening. And if she come for the first time and she is more than 75 years and the one test is positive, two are negative, then we will continue three successive tests until the three negative successive test comes, it will be adequate. And then in the last 10 years, and negative cytology. Then is the table normal, the cytology routine screening. We do routine screening in 3 years. If the sample is inadequate, then we will say that repeat the cytology in 3 months. And if the sample is adequate and there is no transitional zone, that is a scamocolumnar junction, then we will routine screening in 3 years. If the ascus is atypical glandular cells of unknown significance, and if the woman is age is less than 30, then we will repeat cytology in 6 months. And it is if it is negative, then we will repeat again cytology, which means that we will do cytology for two times in a 1 year, in 6 months time. And if both negative, then we will do for recommend the patient for the routine screening after 1 year almost. And if the then is if the we will repeat a cytology in 6 months, and if the ascus is again positive, then we will straight away do colposcopy. We will not do again the cytology. Then is for if this if there will be ascus. And then if the woman is age more than 30, then we will recommend HPV DNA testing, but it is not government funded. So we have to offer it, and the patient has to pay for it, the HPV DNA testing. And it comes if it comes negative, then we will repeat a cytology in about 6 months. And if it comes positive, then we do colposcopy. Majority of the cases we do colposcopy when the things they are positive, or when then we do or if there's ascus, then we do colposcopy. Then if it's ASCH, that is abnormal squamous cells, or that cannot rule out HSIL. HSIL is a high grade squamous intraepithelial lesion. Then is we will do colposcopy. And if it is agus is atypical, or agus is this is the name is atypical glandular cells. Yeah, agas is atypical glandular cells of unknown significance, or atypical endocervical cells, or atypical endometrial cells. Then we will do colposcopy plus endometrial sampling, because it has endometrial cells atypical. That's why we'll do endometrial sampling. Then if there's LSIL, that is the low grade squamous intraepithelial lesion. In this, we will do colposcopy in one side, and other side we will do cytology repeat in 6 months. And basically we are offering two things because of the risk factors. If there's a woman young age and she has multiple sexual partners, then we will do straight away colposcopy. But if there is a monogamous relationship, then we will wait that test will become again negative. So we will repeat cytology in some time in 6 months. So if it is negative, then we will again repeat a cytology like we did in that one, the ASCUS. And then if it is negative, then we will do routine screening. And if I repeat cytology and it becomes like ASCUS, then we will do colposcopy. The like we did in ASCUS in the previous one. Then is the HSIL. HSIL is a high grade squamous intraepithelial lesion. We will do straight away colposcopy. And squamous carcinoma, we do colposcopy. In the majority of cases, when there is a problem and there is some atypical features, then we will do colposcopy. Yeah.
Thank you, Anam, for repeating it.